Okay, so this is a 67-year-old and this case is being shown for the purpose of showing cabbage versus multifacii, where it is effective, where it is not. And in this patient, I think it's very difficult to make a case for cabbage, mainly because of the view based on the anatomy, because it's all very diffuse disease. But we as interventionalists can actually correct these cases in some cases, but you have to work hard. So this is a 67-year-old triple vessel disease, diabetic, hypertensive, class 3-4 angina. Very difficult to get into this. It's a calcified lesion. The stent wasn't passing. You had to crack open with this balloon for 2.5 and it's so even then the stent was not very easily deliverable, but it's a large OM. So managed to get a stent in with a guide liner support. And actually if you look at this, we use the guide liner right up to the lesion middle and then pushed it in, and then withdrew this and then withdrew the stent. So this is one way of doing this. So this was then became simple and we finished off with a kissing balloon. So this is a fairly acceptable result in the circumflex. After the circumflex, the view of the LED, you can see why I was saying that it's a very difficult cabbage, because this is all severely diseased, and in these cases you could do an appendectomy, but the surgeon would not be able to put a very viable Lima graft and expect it to be taken. Maybe he might, but it will be difficult because there is a lot of diffuse disease, and in this one had to work very hard, crossing it with the Fielder XT and then working on it with multiple balloons. And these balloons, some of them busted, so sequentially upgrading the balloon and then doing the wiring the OM, just the diagonal, just to keep it open. So finally, after lot of ballooning for about half an hour and having preserved the diagonal and getting a shape out of the LED, you can see that it's now shaping up. So we embarked on total revascularization of the LED territory by doing multiple stenting. So the first stent goes in the middle because no stent will track distally. And once you've done that, then you have enough leeway to post-dilate and then get another stent distally. So this is my view about getting the stent, free. So before that, we managed to put a guide liner in and track this stent through all this metal distally, and so this is the distal stent come in, and finally after having optimized it, you can see that the result is pretty good. So now you have stents in distally, and sorry, we did miss a bit. We have already stented the proximal part here. So this is the final result, and you can see that how it looked like before, and now this is a pretty good looking LED, and I don't think that cabbage result would have shown any better revascularization in this case. So just to recap, that you can actually get a good result by working hard, and if you have the right equipment. So we managed to preserve that, and I think this patient angina will definitely improve. How long will this result last is anybody's guess.